Chapter 57, Sexually Transmitted Diseases. We know what sexually transmitted infections are. These are infectious diseases, usually viral or bacterial, spread through sexual contact. Most are easily cured, though still a very serious health threat if left untreated. They can take many different forms: bacterial infections such as chlamydia, gonorrhea, or syphilis, or viruses such as genital herpes, HIV, hepatitis B and C, HPV, or even parasitic in the case of trichomoniasis. STIs can be spread many different ways, from skin to skin contact in the case of HPV, via blood and blood products in the case of HIV, especially mother to baby, or autoinoculation, that is the spread through the touch of the infection itself. These are not typically transmitted through inanimate objects or casual contact. For the most part, we need significant sexual contact to spread these infections. Unfortunately, the rates of STIs are at an all-time high. Nearly 26 million new infections occur each year in the United States, costing nearly 16 billion in healthcare costs. And all sexually active persons are at risk. And there's many contributing factors to this, including socioeconomic factors, decreased condom use, cuts to STD programs across the country, and I would definitely also include Tinder and Facebook in this. We can blame Mark Zuckerberg as well if you'd like. Having one STI increases the risk of getting another further down the road, because the same practices that cause that person to catch one STI definitely opens the door for others as well. And a person can have more than one STI at a time. All sexually transmitted infections have an incubation period, and that means the time from the initial infection to the times that symptoms first appear or screening tests are positive. And unfortunately, this is where transmission can still occur while the patient shows no symptoms at all. In the United States, all cases of gonorrhea, syphilis, and chlamydia must be reported to the public health authorities for surveillance and partner notification. Attempts to prevent and control the spread of this disease, track this disease, see where the major outbreaks are, and only a small percentage of new STIs are reported, unfortunately, due to embarrassment and a significant stigma. 2 million cases reported annually does not represent the actual number of infections that are actually out there in society. There are numerous factors affecting that increased incidence of STIs that we're seeing. Everything from early reproductive maturity and the increased longevity of society. While you may not think it, there are significant problems with STIs within the elderly population and even long-term care facilities. Also, issues related to greater sexual freedom than we've seen in generations past. Inconsistent or incorrect use of barrier methods in practicing safe sex. A media emphasis on sexuality. And substance use impairing judgment can all have major parts to play in this increase. Many risk factors for the increased rate: alcohol or drug use, new or multiple sexual partners, more than one sexual partner, sexual partners who have had multiple partners, inconsistent or correct use of condoms, and sharing needles to inject drugs. Anything that could cause body fluid contact and body fluid passing back and forth places that patient at risk. Other risk factors you could identify within that patient's medical history: having one STI places you at a much greater risk for gaining another. Not being vaccinated for STIs that have vaccines, such as hepatitis B or the HPV vaccines. And having multiple courses of non-occupational post-exposure prophylaxis for previous HIV infections. That PrEP medications we talked about last module. And trends in contraception. Male condom is the best route for the best protection. There are certain populations that are at a significantly higher risk of gaining these infections. Youth and young adults, those aged less than 25. The hormones are raging and they are unfortunately known for irresponsible practices. Other ones would be people in correctional facilities and victims of sexual assault, to name a few. Unfortunately, there are many health disparities within STIs as well. And as you'll see from our slide here, many minority groups certainly have higher rates of especially these STIs such as chlamydia, syphilis, and gonorrhea. The increased rates related to these disparities are due to a variety of factors, everything from socioeconomic disadvantages, accessing and affording high-quality sexual health services, fear and distrust of healthcare providers, and even access to these healthcare services that you and I take for granted. Trends in contraceptive use. The male condom is still the best form of protection, other than abstinence, and use has increased in the US, though still many do not use them. Most women also are using hormonal and long acting reversible contraceptives, which, while very effective at preventing unwanted pregnancies, do not provide any barrier protection for STIs. Our first case study. You work in a college student clinic. 20-year-old female and a 21-year-old male enter for an STI screening. KD, the male, has some pain upon urination that began 2 days ago. MP has no symptoms. They want to have unprotected sex in their relationship. Obviously, we've got something going on, especially with KD. And just because MP does not currently have any symptoms does not mean she has not already contracted an STI. A blood test is given to screen for STIs and is performed on both. A culture is also taken from KD's penis. While waiting for the results, MP begins to cry. And in this case, learning about an STI, learning you've contracted an STI, could be very significant, be very hard to process for the patient. There's a very major stigma on STIs for sure. You as the nurse, you want to listen, provide privacy, support her decision to go get testing, and reinforce that STIs are not uncommon in young people. They may feel like they're the only person they know that's had one when they are much more common than you would think. Many signs and symptoms that you should be aware of include discharge and inflammation and pain, and this is especially true for things like chlamydia, gonorrhea, or trichomoniasis. Let's start with talking about chlamydia. The most common STI in the United States, with an estimated 1.6 million new cases each year, and also has an increasing incidence, becoming more and more common. It's caused by a gram-negative bacterium, and it's transmitted through exposure of sexual fluids. Also takes a 1 to 3 week incubation period, making it much easier for the patient to spread it to others before symptoms can begin to appear. The most common site of a chlamydial infection in men is going to be the urethra, whereas the most common site for women is the cervix. Anyone can also get anal and/or oropharynx infections of the disease. While often asymptomatic, men will present with pain on urination or that urethral discharge. Also could rarely have symptoms of testicular pain or swelling. Whereas women are going to have that mucopurulent vaginal discharge, abnormal vaginal bleeding, dysuria, and pain with intercourse. In the case of rectal chlamydial infections, they're going to have anorectal pain, discharge or bleeding, anal pruritus, and in the case of the throat is often asymptomatic or presenting with a sore throat. Figure 57.1 from our textbook. We have a picture here showing the unilateral testicular swelling from chlamydia, with also what appears to be a little bit of discharge there on the tip. The epididymis is a small tube located within the male testes. And in the case of chlamydial infection, this epididymitis can cause infertility in men. For women, it's more pelvic inflammatory disease and can also increase the risk of ectopic pregnancies, infertility, and chronic pelvic pain. For our diagnosis, we want to examine their sexual history, perform a physical exam, and lab tests. A nucleic acid amplification testing, NAAT, is used to identify small amounts of DNA or RNA in the test samples. And this can be accomplished via urethral swabs, urine in both male and female, as well as rectal and oropharyngeal screening and diagnosis. For the care of these patients, we first want to focus on prevention and encourage regular screening in our high-risk populations. Once a patient is identified, we want to begin them on a course of antibiotic treatment. Doxycycline is going to be your most common, though other antibiotics may be used. In the case of doxycycline, we want to take that twice a day for 7 days, though whatever antibiotic this patient is on, we want to make sure that they are both taking it as prescribed and they take the full course of their treatment. Another aspect of treatment is going to be patient education, making sure that all sexual contacts within the previous 60 days are evaluated and treated if possible. Abstain from sex for at least 7 days after treatment or until all partners have been treated and abstained from sex for 7 days. High rates of recurrent infection is possible, and we want to review these risk and reduction methods and make sure that they're returning for repeat testing 3 months after treatment to make sure that the infection is cured. And we want to make absolutely certain that both the patient as well as their sexual partners are treated to prevent that ping pong effect of them passing the infection back and forth. So we treat one, then they end up getting a recurrence from their partner and back and forth in a vicious cycle. The second most common STI in the United States is going to be gonorrhea. With incidence increasing, nearly 600,000 cases were reported each year, with estimates of the actual number being closer to 1.6 million. And this is again caused by a gram-negative bacterium transmitted by exposure to sexual fluids. Unlike other pathogens, prior infection does not provide immunity to subsequent reinfection, which again places them at risk of that ping pong effect we talked about with our previous slide. Men are the most common site is again the urethra, with dysuria, purulent discharge, and epididymitis. And women is again the cervix, with that increased vaginal discharge. All persons can also be infected in the rectum and oropharynx. I'm going to try to spare you from some of the figures from our textbook, but here is a figure of gonorrhea showing that urethral discharge. And from figure 57.3 from our text, here is that endocervical gonorrheal discharge in females. In the case of rectal gonorrhea, micropurulent rectal discharge or bleeding, pain, pruritus, and mucosal coated stools may be present. And in the case of oropharyngeal gonorrhea, there could be few of any symptoms, so the patient could have a sore throat and confuse it with another infection. Men often seek treatment early due to the uncomfortable factor of the symptoms, whereas women are often asymptomatic, with the serious complications related to that lack of care from not realizing that they are actually infected. That pelvic inflammatory disease can later cause ectopic pregnancies, infertility, chronic pelvic pain, as well as the increased risk of them continuing to spread that to others. Unfortunately, gonorrhea does also place the patient at risk of spreading to other parts of the body. Here on figure A on the left-hand side of our screen, we've got a gonorrheal nodule on the hand. And then in figure B, we show that gonorrhea spread to the joint of it's at that pinky toe, I believe. And yeah, again, we're going to be looking for fever, arthralgia, arthritis, and possibly even endocarditis. Unfortunately, gonorrhea can also be spread to neonates as well, with your major danger going to be that infected mother passing it to the child as it's born. And your big danger is going to be them getting that gonorrheal infection of the eyes. It's why former exposure, and they want to always put that antibiotic ointment on the baby's eyes as soon as it's born to make sure that they have not contracted gonorrhea, as it could blind the child. Almost all states require that prophylactic treatment for newborns. There are gender considerations when discussing these STIs. For men, syphilis and gonorrhea is more common, whereas with females, they're more likely to have things like trichomoniasis and herpes simplex too. For men, they're going to have more symptoms that are more readily available, versus for females, unfortunately, these symptoms could be hidden, allowing the disease to progress, creating much more serious problems down the road. For diagnostic studies, we're going to do a thorough history and physical exam, and again, do these same cultures and swabs to isolate and identify exactly which bacterial infection this patient has. Due to the similarity in the symptoms and the different bacterial STIs, treatment's often started before test results come back. And once they've identified which pathogen it is, in the case of gonorrhea, it's often going to be a high dose of IM ceftriaxone. Trichomoniasis. In this case, is caused by a protozoa and is very common in the United States with 2.6 million cases. Often overlooked, better testing methods have improved the detection. And it's much more common among women than men, particularly among women who also have HIV. Trichomoniasis is again spread by the exposure to sexual fluids and has an incubation period of 1 week to 1 month or longer. And infection provides no protection to future reinfections. Unfortunately, this is going to be another case where if a patient has it once, they're not going to have the ability to prevent and fight it off in the future. Again, just like with our other STIs, the most common site of infection for men is going to be that urethra, with the cervix for women. It's uncommon to find an infected rectum and not known to infect the oropharynx. Routine screening for high risk women, especially, is recommended. Most cases of trichomoniasis are asymptomatic, with men reporting burning with urination or ejaculation, or again that urethral discharge. For women, it's going to be painful urination, vaginal itching, painful intercourse, bleeding after sex, or yellow green discharge with a foul odor. If left untreated, the patient can develop inflammation and irritation in the genital tract, and it makes a person more likely to acquire or transmit other STIs, particularly HIV. For diagnostic studies, again, we're going to be involving cultures, analyzing those secretions, and possibly even direct visualization of the protozoa under a microscope. For therapy, your first line treatment is going to be metronidazole or Flagyl. We also want to make sure we're educating this patient to abstain from sex for 7 days after treatment and make sure that all partners have abstained as well. Treat all sexual partners within the past 60 days and educate all of them to return with persistent or if the symptoms recur. Also, follow up education again on those barrier methods, safe sexual practices, and to repeat testing again in 3 months. Other STIs to be aware of are those characterized by genital lesions or ulcers, such as a case of genital herpes, genital warts, or syphilis. Another extremely common infection within the United States is genital herpes, which is unfortunately a lifelong, incurable infection. And it would come in two strains. That would be herpes simplex virus type 1 or herpes simplex virus type 2, with type 1 infecting the oral route or mouth and type 2 infecting the genitals. There are up to 18.6 million people in the United States affected, with the infection rate twice as high among women. Most new infections are transmitted by someone who does not even know they have the disease. Genital herpes is a virus that enters through the mucosal membranes and breaks in during skin during contact with another infected person. The virus reproduces inside the cell and spreads to surrounding cells. This virus then enters peripheral or autonomic nerve endings and ascends to the sensory or autonomic nerve ganglions. And this is what makes genital herpes so hard to treat and so frequent recurrence, and that virus is now living within the nervous system. And while we can treat the outbreaks, there is not much we can do to rid that nervous system of the virus itself. For both herpes simplex virus 1 and 2, transmission occurs through direct contact when an infected individual is symptomatic. Asymptomatic viral shedding occurs without symptoms being apparent. It's impossible to predict when this will occur or for how long. Formerly, both herpes simplex virus 1 and 2 were mainly associated with lesions. Currently, both 1 and 2 can cause genital, anal, and orolabial infections. It's rare to have herpes simplex virus 2 infect the mouth. From figures 57.5 in our text, here is one of those oral herpes simplex virus lesions. For diagnostic purposes, herpes simplex virus 1 infections are most common above the waist, in the upper respiratory tract, dermis, the gums, and versus herpes simplex virus 2 infections almost always occur below the waist in the genital tract, perineum, or anus. Having type 1 does not protect you against getting the other. During the primary episode, there is an incubation period of 2 to 12 days. And again, this is primarily asymptomatic. If symptoms occur, they follow in stages, beginning with the prodromal stage. And this is the period before lesions appear, and present with burning, itching, and tingling. This would be followed by the vesicular stage, where a few to multiple small painful vesicles appear on the buttocks, inner thigh, penis, scrotum, and contain large quantities of infectious particles. Following this would be the ulcerative stage, where the lesion ruptures and forms shallow, moist ulcerations. And then finally, in the final stage, spontaneous crusting and epithelialization will occur at the lesions. The process through these stages varies and may take up to 3 weeks, and could also include symptoms like local inflammation, flu-like symptoms, or painful urination. And while recurrence may happen, symptoms are less severe. The lesions usually heal more quickly as the disease progresses and reoccurs. And herpes simplex 1 genital infections recur less frequency than herpes simplex 2 infections. Over time, both decrease in frequency. Common triggers for reoccurrence include things like stress, fatigue, sunburn, general illness, immunosuppression, menses, or local trauma at the site of the infection. They may experience that prodromal symptoms, but the greatest risk of transmitting infection exists when the active lesions are present. It's possible to transmit the virus when there are no visual lesions or symptoms present, though it does make it much more likely to transmit when there are these lesions in active state. The majority of herpes simplex virus transmissions occur during these asymptomatic periods. Other rare but serious complications of the virus include things like blindness, encephalitis, and aseptic meningitis due to the infection of the nervous system. Genital ulcers can also increase the risk of acquiring HIV due to this opening beyond the skin barrier. And unfortunately, it can also be transmitted from the mother to the baby during birth. The highest risk during these primary episodes, and for the child, can infect the skin, eyes, mouth, and central nervous system. Unfortunately, due to the lifelong diagnosis, genital herpes infections can have an impact on the patient's psychological well-being, relationships, and sexual lives. Teach the patients how to talk to sexual partners, making sure they're not keeping it hidden. You do not want to be spreading that to other partners. Refer them to counseling. Help the patients understand their treatment options and how to manage flare-ups and manage this condition, and understand that this is not life-threatening. For diagnosis, we're again going to begin with a sexual history and physical exam, hoping the patient will self-report or even confirm by visualizing the lesions. For viral isolation by tissue culture, we're going to culture those lesions to differentiate between herpes simplex virus 1 and herpes simplex virus 2. And again, while there is no cure for herpes, their antiviral medications can be very effective at shortening the duration of viral shedding, shortening the healing time of these lesions, and reducing the frequency of outbreaks by 80%. Treatment should be started before diagnosis confirmation. As soon as herpes is suspected, we want to be very proactive in beginning this patient on treatment. There are 3 different antiviral agents commonly given: acyclovir, famciclovir, or valacyclovir, and they're prescribed for both primary and recurrent infections. Can be used daily as a suppressive therapy, and while this reduces their risk of transmitting it to others, it does not cure them or prevent them from transmitting it to others, meaning transmission is still possible, just less likely. As far as patient education goes, we want to make sure we're including information on how to identify triggers, how to identify active outbreaks, practice good hygiene, keep those lesions clean and dry, local anesthetics if the pain gets severe, including analgesics and ice packs as well. Moving on to another major viral STI would be HPV, human papillomavirus, genital warts. There are about 100 different types of HPV, 40% of which are sexually transmitted. There are high-risk strains as well that cause cancer of the genital tract, anus, or oropharynx. 90% of genital and anal warts are caused by that HPV type 6 and 11. Type 16 and 18 cause 70% of cervical cancer, most anal, and some throat cancers. Most sexually active people will be infected at some point in their lives. These are extremely common. And it's not reportable in most states. HPV is transmitted by skin-to-skin contact, mostly during vaginal, anal, or oral sex. An incubation period ranges from weeks to months to years later. Infection with one type of HPV does not prevent infection with another. A little underlying pathology for genital warts. The basal epithelial cells infected with that human papillomavirus undergo a transformation and proliferation of that warty growth. And unfortunately, that HPV is also transient. It resolves spontaneously, usually after 1 to 2 years. It can persist when warts are no longer visible after treatment. And it's unclear if removal of warts cures, or even reduces the transmission of the virus. I promise to spare you from some of these pictures. I'm trying, I swear. Anyway, genital warts, most are asymptomatic. Most people are unaware they even have it. Genital or anal warts are the single or multiple papillary growths. May grow and coalesce to form large cauliflower-like masses. Most patients have few lesions. The growths may be pink, pink flesh-colored, or hyperpigmentated. These genital warts can manifest differently depending on things like gender and anatomy. For men, the warts on the penis and scrotum in or around the anus or within the urethra. And for women, it is warts on the inner thigh, vulva, vagina, cervix, perineum, and internal or external anus. Angiogenital warts can be itchy, cause bleeding with defecation. Most early lesions are not visually detectable. On the positive side, while extremely common, there are a few long-term complications. HPV strains that cause warts do not cause cancer. Certain high-risk strains, like type 16 and 18, can lead to cancer of the cervix, vagina, vulva, penis, anus, or oropharynx. And there's a psychosocial burden as well, cosmetic appearances, and a long-term course of treatment. And in pregnancy, warts grow rapidly and increase in size. They're extremely common. Michael Douglas got them. They're much more common than you would think. But fortunately, they are curable, and your body can often fight off the virus on its own. Even more of a good news, there is currently a vaccine that's being given to younger kids, teenagers. While many of us missed the boat on that, it may be possible to eradicate HPV types if all youths are vaccinated. It protects against type 6, 11, 16, 18, plus 5 other high-risk HPV types. And the CDC recommends all 11 to 12-year-olds be vaccinated. Maybe with some luck and these vaccines remain effective. Hopefully this can be a thing of the past eventually. These vaccines are designed to protect against strains causing 90% of the angiogenital warts and cervical cancers, also penile, anal, and throat HPV-related cancers. It does not treat an active HPV infection. It's just like any other vaccine, it providing that body with the antibodies it needs to fight that infection off right from the start. Our primary goal of treatment is going to be the removal of symptomatic warts. There's going to be chemical methods in the office, ablative methods, or patient-applied topical treatments. Unfortunately, this treatment is mainly designed at minimizing the symptoms. The treatment may or may not decrease infectivity and does not destroy the virus, just removing that infective tissue. Modify treatment if not available or if they can't tolerate the side effects. Moving on to another bacterial STI, let's talk syphilis. It can cause serious long-term complications if not effectively treated in the United States. There's over 35,000 cases reported annually. Likely 150,000 cases due to undiagnosed infections. And unfortunately, that incidence is increasing significantly. It's been very common. Syphilis used to be an even bigger problem back before antibiotics. Syphilis was potentially a death sentence. Al Capone actually had syphilis, was released early from Alcatraz because his untreated syphilis was actually causing neurological damage to the point where he was severely developmentally disabled. They say he had the mind of a 12-year-old when they finally released him. Syphilis etiology. It is a bacteria spread by the transmission due to direct contact with a syphilis ulcer or through the mucosa of an infected person. Can affect the genitals, anus, lips, vagina, rectum, mouth, or tongue. The incubation period averages 21 days but can range from 10 up to 90. An infection does not provide protection from reinfection. Just because you've had syphilis, fought it off, were cured, you are still susceptible and could get the disease again. Unfortunately, syphilis is another STI that can be transmitted from an infected mother to the fetus. There's a high risk for stillbirth or complications after birth, including seizures, death, and the incidence of congenital syphilis in the United States has risen 185% since 2014. Syphilis is often called the great imitator because it mimics a number of other diseases and STIs. Unfortunately, you're noticing a lot of crossover and similarities between all these bacterial STIs, syphilis, gonorrhea, chlamydia. And unfortunately, it's more difficult to recognize, which delays treatment. progresses to specific clinical stages, progresses into that nervous system where it can cause serious damage. The stages of syphilis, beginning with the primary stage. This is the highly infectious, duration of 3 to 6 weeks, with single or multiple cancers or ulcers, and unnoticed if these ulcers are internal. This would be immediately followed by the secondary stage, where the patients are highly infectious, occurs a few weeks after that primary ulcer heals, and a duration of 1 to 2 years. Would also include things like a systemic flu-like symptoms, mucus patches in the mouth, tongue, or cervix, and symmetric non-pruritic micropapillar rash on the palms. Even without treatment, rash will resolve, but the patient still has syphilis and is infectious. Hopefully that color scheme's showing across on your projector, and we've just got those oral tongue effects of secondary syphilis. And here's another one, figure 57.10 from your textbook, showing those rashes on the palms of the hands. And then last but not least, we have that final stage, tertiary or late syphilis, where there's no obvious symptoms. Organ damage is silently occurring over many years, even with the patient being unaware. Inflammatory tumor-like response to syphilis. The gums can irreparably damage to skin, bone, liver, cardiovascular aneurysms, aortic valve insufficiency. This is an STI that can quickly go systemic and have seriously negative consequences on multiple parts of the body simultaneously. Here's one of those skin gummas or those syphilis ulcers on the base of the penis. Some of your major complications are going to be these ulcers inside the genital or anus cavity, and those openings, again, increase their likelihood of contracting, both spreading or contracting HIV due to that wide open skin breakdown. Patients with HIV and syphilis are at the greatest risk for significant CNS involvement as well, due to their decreased immune system allowing that syphilis to run wild. For diagnostics, we'd be looking at a blood test for screening and staging the infection. And remember, remains positive even after treatment, so cannot be used to detect reinfection. Other options would be non-treponemal tests to detect antibodies not specific for syphilis. And these are positive for 10 to 14 days after each ulcer. When positive or reactive tests will read as a titer and increase exponentially. These values would continue to climb during primary and secondary stages of the disease and fall back to negative or non-reactive several months after treatment. Even more disturbing, there are false negative and false positive tests that can occur. During primary syphilis, if done before antibodies are produced, the patient may have other diseases as well. Positive screening tests are always confirmed. Once a person has tested positive, the test may remain positive in spite of that successful treatment. Just as with many other STIs, screening is very important. We want to catch these cases and get treatment as early as possible. Drug therapy is that early treatment, and we really want to focus on eradicating that syphilic organisms. We're going to be looking at our antibiotics again, doxycycline, tetracycline, and treat all sexual contacts from the previous 90 days. As with all STIs, we want to get a very accurate sexual health history, and a lot of this subjective data is going to be due with their current sexual activity with individuals with STIs, their past history of STIs, their sexual partners, and unsafe sexual practices. We also want to make sure we're assessing their functional health patterns. Their nutritional intake, their elimination, their cognitive, perceptual, and sexual reproductive habits. And it's going to take a very thorough assessment to both identify what risks this patient is currently facing as well as the risks they pose to others and their partners. And we also want to have a real good physical examination as well, including integumentary, GI, urinary, reproductive, and make sure we're really checking every part of that patient to find any ulcers that even they may not know about. Other things to assess would be the patient's number of partners in the last month, number of partners in the last year, the types of partners, the types of birth control that they use, any history of sexually transmitted infections, and also drug and alcohol use. Remember, we're going to be very neutral demeanor for these. This is going to be a very embarrassing time for the patient. Don't be afraid to ask questions. We really want an accurate assessment, but at the same time, we want to be very neutral demeanor with this as well, because it's got to be a very difficult time for the patient. Other clinical problems, nursing diagnoses, would be impaired sexual functioning, risk for infections, as well as both the treating their current infection, as well as making sure they're not spreading it to others as well. For planning and education, we're going to make sure the patient understands the modes of transmission and the risks relating to their STIs. Follow that complete treatment plan. Notify or assist in notifying all sexual contacts, and remain abstinent until that infection is resolved and all partners are treated. Health promotion is going to be another key factor of this, helping to prevent these infections before they have a chance to occur. Discussing safe sex practices and harm reduction. Limiting sex to an established monogamous relationship. And address issues related to drug and alcohol dependence. Other education and measures to prevent infections would include helping the patient be aware of specific signs and symptoms. Teach them to notice their partner's genitals before sex, which would be a great practice. Remind them most STIs have no symptoms and can still be transmissible despite that asymptomatic nature. And when having sex, they're being exposed to infections of everyone with whom their partner has ever had sex with. Measures to prevent infection include proper condom use, female condom use, male condom use, and refusal of sex without condoms. Those condoms really are that best method to prevent infections. Other great public health initiatives would be screening programs, hoping to catch cases of these STIs that maybe even the patient is unaware of. CDC recommendations for screening for young people, pregnant women, and anyone at an increased risk for exposure to STIs. When a case is identified, find and examine all sexual contacts of patients with a reported STI. Initiate treatment, though use discretion. This is going to be very embarrassing for everyone involved. And patient privacy is always ensured. HIPAA applies everywhere, and especially in the case of a sensitive subject like sexually transmitted infections. For education, we should be encouraging community education, targeting high-risk populations, and be aware of the difficulty of talking about these issues. Encourage HPV vaccinations, give parents accurate and current information to decrease factors, and stress that cancer prevention. A lot of people look at HPV, it's this benign thing. It is very common, and unfortunately, there are many strains that can lead to some very serious cancers down the road. During our acute care for all STIs, we want to be providing psychological support. Providing counseling. They may have to consider issues of infidelity, may have to consider that there is no cure, and may have to deal with a prolonged, costly, unpleasant, and a long-term course of treatment to eradicate this from both themselves and their partners. Keep in mind that patient education and public health is one of your key roles as a nurse. You are in a position to teach about treatment measures and the need for follow-up care. Teach about the concerns related to non-adherence, the importance of getting treatment, the dangers of that poses both to themselves as well as passing to others, and advise the patients to inform sexual contacts regardless of the presence of symptoms. Some hygiene measures to avoid the risks or lower the risks following unprotected sex would include washing hands. Do not itch or scratch infection sites to avoid auto-inoculation of STIs, just meaning spreading it to other parts of the body. Wash with soap and water afterwards, and make sure to avoid after sex. Can help to decrease the exposure to the STIs by flushing out that urethra. Sexual activity, stress the importance of abstinence, long-term precautions. Stress that treatment can take up to a week and patients can remain infective. Use condoms and other barrier methods. Warn of the complications. This is going to be a danger that will, unfortunately, has always been present within society. And just that good education of everything we can do to limit the spread. Other things to keep in mind. Many patients can have a casual attitude about STIs because a cure can happen with a single or short course of antibiotics for a lot of these. And also, remember, for NCLEX, ATI, this comes up a lot, that almost every state in D.C. have laws that allow minors to consent to STI services without parental consent. Also, keep in mind your mandatory reporting to public health services. That's going to come up in ATI and NCLEX a lot as well. If you'll get a question, which one of these diseases should be reported to the public health department? And a lot of times it's going to be one of these very, very contagious STIs. Patients with an STI will understand the course, modes of transmission, and the treatment options, realize potential for long-term complications if left untreated, adhere to that treatment plan, and understand the importance of partner notification and treatment. They're going to be embarrassed, but it's very important that they notify all partners to prevent further spread to the public. And wrapping up, the nurse teaches a patient about drug use to treat genital herpes. Which drug should the nurse include in the patient's instructions? Would that be A, acyclovir ointment, B, oral acyclovir, C, human papillomavirus vaccine, or D, podophylox topical gel? And that answer is going to be B, oral acyclovir. All right, and that is the last slide we have in this chapter. Yeah, I know this was not an easy one for you to sit through. Luckily, I think it's almost lunchtime for you, so right on time. Anyway, if you have any questions, I know we've got a lot of difficult chapters this week dealing with infections, STIs, cancers. We've got a lot of material in this module coming up on the test. Seriously, let me know if you have any questions on any of this while studying. I know it was difficult. I'm hoping my daughters never find this video on YouTube one day. Yeah, maybe I'll show it to them in middle school. Good information, get to watch them squirm. Anyway, that's all I've got for you in this slides.